So enteral therapy, typically it's a way to provide nutrients to a patient who has a functioning GI tract. And really, for anyone who has a functioning GI tract, it's almost always universal. This is where we go. We don't really go with parenteral nutrition for a patient when the gut is functioning and we can use the gut. Where we wouldn't want to do enteral nutrition is someone who has had a bowel obstruction, they've had uncontrolled vomiting, they've had very recent surgery for which you're trying to do bowel rest for some reason. But short of that, most patients can be managed on enteral nutrition solution. And then the modes of delivery depend on whether or not your short-term or long-term goal. With a short-term goal, you can do a nasogastric, nasoduodenal, or nasojejunal tube. But for longer term, you need a surgical implant for another tube that will then ultimately dwell, particularly where it's going to dwell. Usually in the jejunum is usually what we'll see. The schedule of administration, there are continuous infusions, there's cyclic infusions, intermittent infusions, or bolus administrations. Each of these have their advantages and disadvantages, and you're going to choose them based on guidance from clinical nutrition, but also what's practical for the patient. And you also have to think about whether or not the enteral feeding interacts with an orally administered med. And so while it is often considered to do a cyclic infusion, every 6 hours to give a bolus feed or something like that, if you don't time the meds that might bind to that bolus feed and affect the absorption of that med, then you end up with, if anybody changes anything in the timing, you affect the absorption. You see a lot of variation in drug response. So you need to be kind of careful of that. There are lots of ways we can administer enteral feeds. It can be by a syringe, by a gravity drip chamber, or by a pump. The components in an enteral nutrition are going to be really the same components we're going to use in parenteral, and they're the three macronutrients we think of: the amino acids, the carbohydrates, and the fats. Amino acids might be adjusted based on whether or not there are certain amino acids you're shooting for or not, based on comorbidities like particularly liver failure or renal failure. Carbohydrates are typically simple sugars that are somewhat calorie dense, and particularly fats are very calorie dense. And you're going to mix the choice of amino acids, carbohydrates, and fats to an optimal level with input from clinical nutrition about how to do that and how much of that to do. Other components are going to be in enteral nutrition include electrolytes, vitamins, trace elements, and probably one of the biggest risks for enteral nutrition is an aspiration pneumonitis. And so you need to be careful about what that aspiration risk is for a patient, particularly if they have a nasogastric tube of some sort, where that could be a risk for, and they have a risk for aspiration. So you need to watch for that, but that risk is still lower than maybe it would be if a patient were eating themselves. So in developing a plan, there's a couple of charts that we'll have through the nutrition section. I encourage you to sort of step through them, but they look at how you determine caloric requirements, which formula they'll pick at what calorie per milliliter. You also could need to consider volume that's going to be tolerated for the patient. You want to make sure they have enough of each component, particularly protein. And you want to also look at, depending on how much carb is added or dextrose is added to that solution, is that going to affect their glycemic index and their glycemic response if you need to monitor for blood sugar. In addition, the protein, you need to think about, are you trying to limit proteins because the patient has already albuminuria or something? So all of that is sort of managed pro and con. The routes of administration of parenteral nutrition, on the other hand, parenteral is limited to those folks who can't tolerate enteral nutrition and need nutrition, and usually in the hospital for patients who have not had enteral feedings for 3, 4, or 5 days, that automatically triggers a nutrition consult to evaluate whether parenteral nutrition makes sense. And then you need to look at whether you have a central line or a peripheral line. The problem with peripheral line solutions are that you can't get enough calories in an osmotically neutral or hypertonic solution that can be tolerated in a peripheral line, you can't get enough calories in that volume because you're usually limited to 2 or 3 liters per day. So you need to sort of keep that in mind. So the 3 components in a parenteral nutrition solution are amino acids, dextrose, and fats. And with a central line solution, we are capable of achieving really all the calories we need in that 2 or 3 liters because we can give more dextrose and higher amounts of amino acid because it's hypertonic solution, but that can be tolerated in a central line where that wouldn't be tolerated in a peripheral line. So the things we're thinking about here are the amino acids. First off is we'll look at what amino acids they need and how much, and that depends. The requirements as a default are recommended based on adults or children. So we'll sort of consider that. The complications might be elevated BUN, hepatic coma. The formulations might be specialized based on existing liver or something like that. And we need to be careful about the higher percentage rates of amino acids as they're hypertonic and have to be given only as a central line solution. For dextrose, these are non-protein calories. We need to look at glycemic control for patients, but it's a way to give a lot of calories. We often, in diabetic patients, have to adjust their insulin regimens with a TPN. Historically, we used to actually add insulin to a TPN bag, but we don't do that really much anymore because it makes it harder to titrate or adjust the dose once it's already in the bag. And its administration, the concentration of dextrose, if it is a concentration that is greater than 10%, even greater than 5% in most solutions, we often have to consider giving it by a central line, not a peripheral line. So we really opt for long-term management and nutrition support for a central line to get enough calories in a 3-liter solution for a patient because of its high osmotic pressure. And finally, fats or lipids are the most calorie dense of all. And we're going to look to give it as to either prevent or reverse an essential fatty acid deficiency in patients. But we need to be careful about how much fats we give and how we administer them. But that's also done sort of in a pretty standardized way. We're also going to look at in that IV solution to make up for what we think is going to be their potassium, sodium, calcium, mag, phos levels. And we're going to also make sure they have adequate trace elements and vitamins in those solutions as well. Often the parental solutions will contain either a mix of the dextrose and amino acids with the lipids given as a separate IV, or it could be given where all 3 are mixed in the same bag. So here are some of the osmolarity components associated with each of these components that affect whether or not the drug can be given centrally or peripherally. And the advantages and disadvantage of a 2-in-1. A 2-in-1 is an IV solution with just dextrose and amino acid where we give the lipids separately, and a 3-in-1 is a bag that has lipids plus dextrose plus amino acids in it. And so there are advantages and disadvantages to each that are listed here. And then there are a few tables here that will list examples of calculating central parenteral nutrition and peripheral parenteral nutrition solutions. I encourage you to just let your eyes scan across these as a process that's done, but this is routinely done by the clinical nutrition service in most hospitals with partnering with the pharmacy, and then they'll present their recommendation to you with explanation of why they picked what they picked, and then you as a clinician can say a veto or say, yes, that's what we want, this meets the goals of this patient, or no, there's some other variable you know about this patient that those clinicians didn't, and you'd adjust accordingly. So you'll find which of the solutions, for example, they come upon which what the macronutrients are, and then they'll look at adding the micronutrients as well. Here's an example of a calculation for a peripheral solution. These are usually less calorically dense, and they don't even usually meet the full caloric requirements for a patient, usually because we can't provide enough calories to meet that need for that patient. All that a parenteral solution can do probably and achieve without a fluid overload is to stem the tide of, provide some calories, but usually not enough for what the patient will likely need. Further examples of that peripheral calculation. We also look at vitamins, and vitamins are added to the parenteral and enteral nutritions. They're organic compounds. They're needed for usually some metabolic or essential process in the body. And so each of these vitamins will go through some of these, and these can be given enterally or parenterally. Most people who take a multivitamin, for example, contain most of these vitamins. If someone's diet is good and they're eating lots of, vegetables and fruits and other sort of standard things in a good healthy diet, they probably don't need supplemental vitamins at all. But a lot of Americans who don't necessarily eat as well as we should, many of them will find that a multivitamin sort of is a little bit of insurance, perhaps, that they're not going to have a deficiency in one of the more common vitamins. So vitamin allowances are periodically updated, and the recommendations are usually looked at a recommended dietary allowance or an adequate intake. There are a couple other different ways that we may look at those allowances, but most of the time they're posted on, and labeling requires the manufacturer to list what the amount of each ingredient in a multivitamin is and how that compares to what a recommended daily allowance is, what percentage of the daily allowance is achieved by a single dose of that multivitamin. So let's first look at the fat-soluble vitamins, and then we'll look at the water-soluble vitamins. The fat-soluble vitamins are vitamins A, D, E, and K, and let's talk a bit about each of these quickly. Vitamin A, or retinol, has multiple functions. We kind of think of vitamin A as having a role in allowing the eyes to adapt to dim light and to maintain skin and mucous membrane integrity. Typically, sources include fatty things like butter, eggs, milk, liver, and drugs with high levels of beta-carotene, such as carrots and, to some degree, tomatoes, spinach, and pumpkin. The units are listed here. The typical minimum daily requirement is about 1,000 to 800 to 1,000 units, and or equivalents, and it's fat absorbed. And these issues we think of is that the fat-soluble multivitamins or the fat-soluble vitamins, when they're administered, will stay in the body a long time. So you can actually become toxic in any of the fat-soluble vitamins by intaking too much. So we need to be careful about that. Deficiency of vitamin A can lead to night blindness. We can also see other complications associated with it, including skin lesions and changes in mucous membrane. But we have to keep in mind that vitamin A derivatives, particularly in high dose, are potentially teratogenic. And so we need to worry about, for example, a standard multivitamin is not going to be teratogenic. But a woman who goes to a nutrition center and has these mega doses of vitamin A, that could be potentially teratogenic, and we need to be careful about that and avoid excessive amounts of vitamin A. Therapeutically, we usually use it just to correct the deficiency. Under the derm section, we talk about some of these vitamin A derivatives for treating, among other things, acne and some other dermatologic conditions as well. Beta-carotene is a converted to vitamin A, provides for skin health as well as probably some eye health as well. Let's go on to vitamin D that we've talked about, or we talk about in the renal block here. But vitamin D is important in the regulation of calcium and phos levels. In children, it causes rickets. In adults, osteomalacia, deficiency of it does. And excessive amounts are also problematic in that they're fat soluble, they accumulate, and they can also contribute to a risk for hypercalcemia. Vitamin E, the role of vitamin E in humans is less than fully clear. There was believed at one point about a decade or two ago that vitamin E was essential for cardiac health. And we even had cardiologists often ordering vitamin E for their patients. But the data for that is scant at best. And so we basically don't see that as a routine practice anymore. It probably has some antioxidant properties. I think that most clinicians would say, look, if you're getting a diet that has an adequate amount of vitamin E in it, or you're taking a multivitamin that has a little vitamin E in it, you're probably perfectly fine. Vitamin K, particularly related to clotting factors. We talk a bit about this. We talk about warfarin and coumadin when we talk about the antithrombotics. There are lots of sources, but we usually think of green leafy vegetables as a source, and it will maintain the production of clotting factors in someone who also has a functioning liver. So vitamin K, sometimes for folks who are in liver failure, particularly liver failure secondary to alcoholism or some other condition, we sometimes see that patients will get doses of vitamin K when they come in the hospital if their INR or PT is high, just to confirm that the reason that their INR is high is not related to a vitamin K deficiency. So we often will see that done. Most of the time the vitamin K doesn't really do much because the reason they are having an elevated INR is they're not making clotting factors because of liver dysfunction, not because of a deficiency in vitamin K, but because vitamin K is required for clotting factors, we sometimes will give a supplement dose. We also give a supplement dose in newborns at a lower dose of a milligram dose standard as a routine process at birth. It's orally requires bile salts for absorption. Its deficiency can include bleeding tendencies because of clotting factors or some other issues, including obstructive jaundice, which is correlated with vitamin K issues. But typically, in most cases, other than a single dose in a newborn or the use of vitamin K around folks who are on vitamin K antagonists, like warfarin, you typically don't see too much vitamin K used. Adverse effects may be hypersensitivity reactions, particularly when we give vitamin K IV. And so we limit IV vitamin K to folks who have severe coagulopathy secondary to warfarin overdose or warfarin overshooting where there is a clear bleeding risk. And then therapeutically, we've alluded to some of the uses of vitamin K here, both here, and the use of vitamin K in the antithrombotic block. Onto the water-soluble vitamins, typically the B vitamins and vitamin C. They differ from one another, but they're all pretty water-soluble. So I've heard people sort of anecdotally joke that if you could have an expensive formulation of vitamin Bs and Cs and you spend a lot of money, and what you end up with is expensive urine, because basically most of these drugs are cleared in the urine. And for the B vitamin complexes in particular, folks may notice that after they take a vitamin supplement with a lot of B vitamins in it, about an hour and a half later, their urine is sort of bright yellow. And that's because many of these vitamins are going to ultimately be cleared in the urine because they're relatively water soluble. So let's first talk about vitamin C. Vitamin C has multiple biochemical reactions that it's involved in. Its sources include citrus fruits and juices, tomatoes, potatoes, other sources as well. Deficiency causing scurvy. And adverse effects in large amounts can cause diarrhea and maybe even crystals in obstructive kidney failure could be a possibility with very high doses of vitamin C. Typically what we're going to see is a dose of usually 500 milligrams to a gram a day for folks who are deficient in vitamin C. And typically if folks have an adequate diet with at least a little bit of citrus in it or tomatoes in it, they're probably fine and don't have a deficiency of vitamin C. The data for Vitamin C, before we as we go on to niacin here, but let me go back for a moment. The data for vitamin C is limited in preventing coughs and colds, so the data is equivocal there. Over the last 4 or 5 years, there's been a lot of discussion about whether vitamin C or ascorbic acid has a role for patients who are in the hospital in the ICU with septic shock, and the data for ascorbic acid IV in such patients is evolving, but the data is probably not particularly solid. So you'll see a lot of debate about vitamin C or ascorbic acid in sepsis in its management, and the data, just let's leave it at this point, is that it's evolving but not solid. All right, on to niacin. Niacin lowers cholesterol levels, and it lowers particularly triglyceride levels, and historically was an agent of choice for elevated triglyceride levels in patients. The problems with high-dose niacin is associated with a lot of flushing, not well tolerated for patients, but a little bit of niacin is a necessity. And so we typically see low to modest doses of niacin well tolerated for patients, but high doses of niacin that we used to use in managing hyperlipidemias, particularly hypertriglyceridemias, are associated with a lot of flushing reactions and even some perhaps liver injury at very high doses. So the deficiency of niacin or nicotinic acid, when it's severe, could lead to pellagra or other GI or CNS problems, but it's generally, only a modest dose is needed to really correct that. Vitamin B2 or riboflavin has a multiple sources in animal and vegetable products. It's excreted in the urine. So one of the things that will cause that bright orange or yellow urine after taking a multivitamin with particularly B2 in it. It's only for the prevention or treatment of a deficiency, which isn't really well seen. Typically what you'll see in a very deficient state might be a sore throat or something else, but typically in not all that widespread deficiency is not all that widespread. And then there's some data about whether high doses might prevent migraine headaches. The data for that is not what I would call solid. It's not a universally accepted modality to give vitamin B2 to prevent migraines. Thiamine. Thiamine, you will see thiamine used extensively in healthcare. And we use thiamine particularly for patients who might be deficient in thiamine, and that's going to be particularly folks who come in with poor nutrition, often secondary to substance abuse, particularly alcohol induced states. If folks have a history of alcoholism, they often will have a concurrent malnutrition, be thiamine deficient, and then they cannot metabolize carbohydrates well. And so thiamine deficiency poses significant risks we'll talk about both here, and we'll talk about under the management of acute alcohol withdrawal. Thiamine is associated in lots of plant and food sources, particularly pork, in peanuts, asparagus, a number of cereals. Deficiency can include wet beriberi or dry beriberi, but most often in alcoholism what we think about is Wernicke-Korsakoff syndrome and other central nervous system manifestations which can result in serious brain injury, so we need to be careful about that. And we never want to give dextrose or carbohydrates to a patient who we know or highly suspect could be thiamine deficient until we give them thiamine. So it's almost universal. Someone comes in with a history of alcohol abuse, we'll give them something like 100 milligrams of thiamine, IM or PO twice a day. If we really think they're thiamine deficient, we could give them 500 milligrams of thiamine, IV or IM or PO. But typically, we often give as a routine protocol someone coming in with a history of alcohol withdrawal or question of alcohol ingestion that's significant over time. We routinely give them thiamine at least 100 milligrams twice a day before we actually give them any dextrose. Vitamin B6 is found in animal and vegetable foods and milk and meat, soybeans, and other grains. And it's typically requires a certain level of metabolism, and it's involved in metabolism of amino acids and proteins. Deficiency in a poor diet could be problematic in a number of cases, but really the medicine that I think of most often where we give pyridoxine to prevent nerve injury is isoniazid. Isoniazid in the management of TB will typically use to prevent neuritis and other issues related to nerve conduction problems. It also might interact with patients with Parkinson's who might be on levodopa, but that's usually not clinically important. And we use it to prevent or treat vitamin B deficient states. Most importantly, we'll give pyridoxine for patients who are on isoniazid to prevent nerve injury. B6 is involved in generation of amino acids and cellular function, but also in nerve conduction as well. Cyanocobalamin or B12 and folic acid, we talk about both of these a bit in the hematology block when we're talking about factors related to the development of red cells. And so for folks who are anemic, usually, particularly if their cells are larger in size, they have a large mean corpuscular volume, then we usually do an evaluation of whether or not they could be folic acid deficient or cyanocobalamin B12 deficient. And B12 deficiency typically is manifest by this anemia, and typically folic acid deficiency is manifest by nerve deficit as well as anemia. So typically when you look at replacing B12, you also just want to make sure that you're not masking folic acid deficiency as well, and make sure you've got sort of both on board. The issue with folic acid deficiency also can be a function of, in a woman of childbearing age, a risk for developing neural tube deficits in a woman early in pregnancy for that fetus. And so we need to make sure that folic acid supplementation is adequate for a woman of childbearing age. So B12 and folate also have some issues as we look at patients who undergo coronary angioplasty. And there's some data that whether or not B12 and B6 and B12 and folate may reduce the risks for cardiac events. This is a small study done 15 years ago, but I think it's the kind of studies that we look at is we just want to make sure that folks have just the adequate amounts of vitamins, and there may be correlated outcomes that affect health that we haven't really measured all that well. And the only reason I include this slide is not to get aggressive about it, but just to consider that nutritional deficits are hard for us to recognize what the true implications are, because we can't always control for that one nutritional deficit or that supplementation very well. And because there's not a big pharma incentive to do these expensive studies well designed, we really don't have them. So I think the bottom line is just making sure that folks have a adequate nutritional support is a part of a bigger picture of cardiac event risks and other health risks. Pantothenic acid, also found in many multivitamins. Usually we don't measure levels or dosing, but it's contained in a multivitamin and responsible for some types of synthesis biochemical processes. Similar for biotin, involved in metabolism of carbohydrates and fats. So as we alluded to already, folic acid important in avoiding certain types of anemias, but also in as it affects nerve conduction and nerve development in a newborn fetus. It's typically found in grains. In fact, most flours in North America are supplemented with folic acid to prevent this as a folic acid deficiency. Chromium as a trace element helps in fat and insulin effects in metabolism. Typically, we'll look at a low to moderate dose being effective for that, and it can result in better glycemic control. So you'll find, for example, in a lot of complementary alternative meds, there's a combination, for example, of cinnamon and chromium supplements for folks who have early metabolic syndrome where they might get a little bit better glycemic control with a little bit of chromium on top of use of cinnamon as a complementary alternative approach for perhaps forestalling the risk for diabetes for a patient at risk with metabolic syndrome. Fish oils, we talked more about fish oil and omega-3 fatty acids in the hyperlipidemia section. Primarily, it's most effective at lowering the risk for hypertriglyceridemias. Selenium found in soil or in dirt, but it's found in lots of other foods and vegetables as an antioxidant that may be associated, among other things, with reducing cancer risk. And zinc has many enzyme functions associated with it, and what's involved, it probably believed to be involved in helping, in, among other things, wound healing. So you want to make sure that folks have adequate zinc in their diet as well. The data for a multivitamin a day depends on which study you look at. Here's a study that's somewhat dated now, a decade and a half old, but looked at comparing, not a big study, not a rigorous study, but looked at multivitamins in patients age 45 or older, and their risk in the vitamin group for infections were lower than in the placebo group. Now, what you can't really tell from these small studies is because it's hard to really know the methodology of how well that really was done in a fairly small sample size, how really true that is. But I think the bottom line is that multivitamins are relatively inexpensive, that if patients don't find a pill burden is problematic, a multivitamin is a routine process for people who don't really have a great diet, probably won't do any harm for a patient if it's a standard multivite that doesn't have excessive amounts of fat-soluble vitamins. Here's another study that looked at multivitamin use in patients who were older in nursing homes, and basically their assessment was that it offered probably maybe some benefit, but there was really no difference in this cohort of infections or emergency visits or hospitalizations or anything else. So depends on the study you see. You're not going to find great data for multivitamins. I think it almost is a sense for a personal health choice for an individual about whether they take a multivitamin or not, but don't put too much stock that a multivitamin is going to do a lot